There's still some people like trickling in. Um, do, 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 do. Or I guess we could just get started. Okay, so welcome everyone. This is a continuation of our PALISI RC subgroups webinar series on various training topics. Today, we are going to be welcoming Lisa Steele, who's one of the coordinators from Nationwide Children's Hospital in Columbus, Ohio. And she is going to be presenting daily AE and SAE screening and review. So yeah, she's like gold standard expert, amazing AE, SAE reviewer. So she's got it down pat, and hopefully we'll all be able to get some good lessons from her today. So yeah, with that, I'll hand it over to you, Lisa, and you can take it away.
All right, thanks, Ryan, so much. I want to just say thank you for asking me to do this. And I did try to change my slide template so that it didn't say Capcorn all over it since I'm presenting for PALISI, but it kept screwing up my format and I was worried I was going to lose my slides. So I originally made this presentation for the Capcorn network, but I have given it to other people. And I just want to say that those of you who are in Capcorn, you have heard this, but I tried to add a few things to it from what I've learned now with the precise study. So, all right, come on. There we go. Okay, so we're just going to do the purpose of it, some definitions. Then we'll go through my screening workflow and then reporting of SAEs. And each site investigator has primary responsibility for surveillance of adverse events. Especially with interventional trials, this is vitally important that this is done each and every day. An adverse event is any untoward medical occurrence in a patient or clinical investigation subject who has been administered a test article or other intervention, even if it does not necessarily have a causal relationship with this treatment. It can be an exacerbation of a pre-existing condition or event. It can be an intercurrent illnesses, drug interactions, the significant worsening of the disease under investigation. Serious adverse event is any untoward event that occurs during the trial that results in death, is life-threatening, requires inpatient hospitalization or prolongation of existing hospitalization, results in persistent or significant disability, incapacity, necessitates medical or surgical intervention for the prevention of treatments of any of the above things. And just in the opinion of the principal investigator, it can be considered a serious adverse event. And this is even if this has nothing to do with the study interventions. We are all familiar with critically ill patients. That's where our research is done most of the time. So we expect there to be adverse events. We expect there to be serious adverse events. Where it comes into play with the PIs is to decide if it's expected, unexpected, related to the intervention or not. So who's responsible for reporting? Ultimately, it is the site investigator. All adverse events should be evaluated by the site investigator. But we all know that the research coordinators will be the ones probably identifying the AEs, but it needs to be somehow documented that you are under the supervision of your PI. It's real important that the PIs are the ones that decide, are these true adverse events? Relatedness, relationship, and the expectedness of the AE must be determined by the PI. That is not something that the research coordinators should be evaluating and determining. Sometimes there have been discussions with the principal investigators, with the coordinators to say, is this really related? Is it not? We all have our levels, different levels of experience and stuff, but it is ultimately the responsibility of the PI. So I threw this slide in. I have a little disclaimer to make. This presentation is to show you that AE screening has to be completed, review definitions and things like that. But from here forward, this is pretty much my process. These are suggestions on how to do and perform your AE screening. This process was started with one of my first research studies that I was involved in. It has been continued to be fine-tuned and stuff. But through the PRECISE trial, I have learned that everyone needs to come up with a process that works for you and your site. So what I'm presenting is what works here at Nationwide, which is what Dr. Hall, how he wants it to be done and stuff. But you need to come up with a process at your site that works for you and your principal investigators. Also, from now being involved in some other interventional studies, some studies will provide details or instructions on what they need screened as an adverse event. They will list, 10 problems that they want these documented as adverse events. Other ones will just say, report anything and everything. Some you'll report what you consider an adverse event or a serious adverse event, and the study team will review it and say, you know what, we don't consider this an adverse event or a serious adverse event, so please remove it from the database or whatever. So just know from what I'm coming forward, I'm going to give you suggestions on what works for us, but these are suggestions and you need to come up with a process that works for you. The biggest thing to come up with that I find the most helpful is to come up with a pre-randomization or pre-medication problem list. You want to list any pre-existing conditions or signs and or symptoms that were present in the subject prior to the start of the study. These should be recorded as either part of the medical history, the physical exam, placed into the study subject file. I make a separate pre-randomization list. We go through the chart and we list all the electrolyte abnormalities. We read through the notes where the nurses may have documented that they're having some agitation, they're more lethargic, things like that. We build all this onto a spreadsheet, which I'll show some examples of. But abnormalities on the pre-randomization problem list don't need to be recorded as an adverse event or serious adverse event unless they worsen significantly or stop and then recur. That's why it's so important to be real thorough with your pre-randomization problem list. It ultimately helps you on your daily AE screening. Did someone have a question? No? Okay. So once again, this is based on the PRECISE study that we're involved in, but I usually start the pre-randomization problem list, at least a draft of it, when we know the patient is going to be eligible for either randomization or study intervention or something. So you could start it on the day of consent if you wanted to, if you had time. But I usually get a start on it ahead of time. So that way, then it's not quite as much of a scramble when you're getting them, tuned up and ready to get started on intervention. So the first place I look at is the medical history. We want to look at those baseline abnormalities or problems. Is this kid one that has a history of seizures? Do they have respiratory insufficiency? They're already on BiPAP. They already have high CO2 levels. They have an immune dysfunction where, some of those really weird labs that you see once or twice during hospitalization, do they already have those as baseline abnormalities? So look to the medical history, see what the family, reports as issues for them. They're always kind of tired. They're always more lethargic. What's their baseline? Look at the admission, hospital history and physical. Why were they admitted? Did they have surgery? What was the surgery for? All those types of things are things that you should list on your pre-randomization problem list. Lab results. This is probably the biggest chunk of what makes up a pre-randomization problem list. And to make things more uniform for us, we note anything on our pre-randomization problem list that is out of hospital range. So if it's highlighted in red, as we do in EPIC, I don't know what Cerner does to identify things, but anything that's noted out of hospital range, we make a note on the pre-randomization problem list. So say a kid has a potassium of 3.6, which technically is hyperkalemia per hospital range. But we all know that that's not really like a significant issue for the patient, but note it down because maybe they continue to have a K level that's slightly elevated. That way, then you don't have to note it every single day when it continues to occur. So make a note of them, even if they're not clinically significant and don't require any intervention. Review radiology reports. This is where you're going to pick up, is there atelectasis? Is there a pneumothorax? Are there effusions? We all know many of these kids have effusions because of just lots of times fluid resuscitation and things like that. Is there pneumonia noted on there? Just be as detailed as you can with that. And then review the nursing notes, review the physician notes each day. This is where you're going to pick up on agitation, delirium, hallucinations, withdrawal, any of those types of issues that might be noted in a nursing note, but don't really fit necessarily into a physical exam. Make it detailed. I usually start out with noting the date and time that the abnormality started, even if it was at a time of admission. And then I kind of screen through each day to see, okay, when did it stop? When did it start? Especially with electrolyte abnormalities, I'll usually give myself a good 48 hours before I say that something has officially resolved, because I learned this on my first study. I would note hyperglycemia and then it would resolve and then it would restart again a day later. So it was constantly starting and stopping, starting and stopping. And, just to give yourself a little bit of grace, because we know these kids are sick. We know they're going to have abnormalities. I usually will give it a good 48 hours before I'll say something stopped. Then, as you're going through the days, you're going to continue up to when randomization occurs. What was present at the time of randomization or study drug start or study intervention, depending on what your time point is for that. And then all findings should be reviewed on subsequent study days for resolution. You're going to note the date and time. Then you'll be able to know, do they start again? Fever is a big one that lots of times, we'll have fever for a couple days and then it resolves for a couple days and then maybe it starts up again and stuff. So you want to make start and stop times for when things start and stop. This is an example of a pre-randomization problem list that I made for one of our former patients. Like I said, I build this on an Excel sheet, and then you'll see in the parentheses, I'll note the value. What was it that, made me note this one? That way, then I'll also have an idea, does it get worse? Does it get better? Is it going to change that now I need to report it even though it was on the pre-randomization list? Does it need to be reported because it got significantly worse? Once I've built it on the spreadsheet, then I copy and paste it into a Word document and have the principal investigator review it and then sign and date it. That way, then we know it has been reviewed and approved by him or her. I will then also just take examples, like I'll take a chunk of the report from a radiology report so that I'm not having to put every single little detail from a radiology report within the body of the randomization list, but I'll just take the summary of the results and put that at the bottom of the report, also which gets copied and pasted onto the Word document. So the patient is randomized, or they're on study intervention, or they've started receiving medications. Now what do we do? So beginning the day of randomization, the investigators will evaluate adverse events on a daily basis. Many times, the study protocol itself will tell you how many days you need to continue to screen for adverse events following either the completion of their randomization, their study participation, their medications being given, things like that. We do for precise, that's why this is in here, that we do through study day 28, hospital discharge or death must be reported on the adverse event log, but it will be up to each, usually it's up to each study. Like I think Crete was 7 days past their last dose of medication and stuff. So they should give you a definition of how long that you need to continue to screen for adverse events. And remember, you're going to put it on the adverse event log, even if it's not considered to be related to randomization or study intervention. This is where the PI, you'll note the hyperkalemia of 3.6, and the PI on their review can determine that that's not really clinically significant, but at least then it shows that you have done a thorough review of the chart and have made notes of that. So we have a daily AE log that we use here at Nationwide Children's, and we fill one of these out per day, and we do basically a 24-hour kind of rolling clock. We lots of times will do our AE screening in the morning, and so we'll do from like 10 o'clock in the morning the day before to 10 o'clock in the morning the day we're reviewing. That way then we're always kind of covering all 24 hours of a day. But if you do adverse event screening per calendar day, you're behind. We do kind of a rolling clock for this 24 hours, and we made this sheet where we'll list the adverse event. Was it new or ongoing? What did we do if we had to start a concomitant med? Many times I'll make a note of what medication did we use to treat this adverse event, things like that. One thing we found was that when we had a monitoring visit, the monitors love this because we also add a signature at the bottom, who prepared the adverse event log for the day, the PI that signed it. But we've also added this little checkbox that if it was reviewed by email, we also send an email each day. Now, I've heard from other sites, they just build everything on a spreadsheet, and the PI and the coordinator sit each day and they review it. And at the end, the PI just signs a physical copy of the spreadsheet or something. Other sites will print out their lab results and they will just have the PI signature next to those and stuff. Whatever works for your site. It just needs to be done. You want to be thorough, and you want to be able to demonstrate that the PI is reviewing things or their designee, because sometimes the lead PI is not available. They should have a designee to review it. This is a new source document for us. We want to review from the last time, which I told you, about 24 hours. If it's a medication study, you want to probably try and complete at least a quick screen to make sure there wasn't anything that is the level of a serious adverse event before ordering that day's drug, or do you have to hold that day's drug because a serious adverse event did happen before the PI can review, things like that. So we do that in the mornings. PIs can then review that daily and write not clinically significant. Mark just makes little NCS in the corner next to the name of the adverse event. He will then do the review of the relatedness and expectedness. He signs and dates it in the time. We've also started adding what day is it in relation to starting study intervention, starting study drug. So we'll write it's after the first dose, it's after the second dose, because if some adverse events have gotten worse that we know are potential complications of medications, potential side effects of intervention, if it continues to get a little bit worse, maybe it is related, and he wants to make a note of that and know that ahead of time. We also do share the information via email, and we just keep a running email going with the daily review. Mark will many times say, understand, got it, as a reply to us, and then we just use that same email so that we have pretty much the whole 28-day chain in one email that I then just save in our shared folder. This is an example of a filled out daily AE log. This was an old version of it. So you can see I wrote down what the adverse event was, what the value was it new or ongoing, and Mark put a little NCS next to the hypophosphatemia because it was not clinically significant. So just shows that he reviewed that. We're going to track the first day that it started and record the worst that it was, because depending on how your database is set up, you probably are going to want to record the worst grade severity that it was, which we'll get into in a little bit, as what gets entered into the database. The spreadsheet for overall tracking helps us to finalize what does go into our electronic database, depending on how your study is set up. Like PDICE-CAP, we have it per day adverse event reporting. We will finalize end dates and things like that on that day. But if it started on day 1, we're going to put it on day 1, and then the final date might not be until day 7. So it all depends on how your study has it set up for their electronic database. This is how we use our spreadsheet for screening, the Excel spreadsheet. The things that are highlighted in yellow were things that were problem at the time of randomization, intervention, start, whatever. So I'm going to track that acidosis. When did it start? When did it resolve? And then it started again. So I add another little line. It started 5 days after the start of intervention, and I'll make a note of what was the worst value that it was. The agitation, the alkalosis, those things that were all new that developed after we had started study intervention and stuff. But I pulled this sheet up, and we have this open when we're doing our screening, because then we can also say the anemia is still ongoing. It was pre-randomization, it's been ongoing. We're now into 7 days later and it's still ongoing. So I'm not going to resolve that yet, but that's how we use the daily log to continue to help with our screening. As I said, you want to give yourself 24 to 48 hours before saying something resolved. That just helps you with some timing and stuff. You don't want to have to write down hyperglycemia every single day if it started and stopped multiple times. So I usually will give myself at least 48 hours for electrolytes. So assessment of severity. So this is standard AE screening and stuff. There's various grades of severity. So mild is an adverse event that is easily tolerated by the patient, causing minimal discomfort and not interfering with everyday activities. So you can think of this as like a sunburn. You get a sunburn, it's there, it bothers you a little bit, but it's not preventing you from doing anything. Moderate is an adverse event that is sufficiently discomforting to interfere with normal everyday activities. So think of a blistering sunburn, that usually is a little bit more uncomfortable, or hurts to put your shirt on, something like that. it does interfere with your everyday living. Severe is an adverse event that is incapacitating and prevents normal everyday activities. So I certainly hope no one ever gets a sunburn that requires grafting, but if a sunburn ever required grafting, that would be pretty severe. And then life-threatening. If there are, you have to intervene to prevent life-threatening consequences. A kid who cardiac arrests, you have to do interventions to prevent them from dying. So those are the grades for assessment of severity. And death. Death is never an adverse event. It is the outcome of an adverse event, but death is not the adverse event. We use the CTCAE guidelines. We use version 5. You can find these just by Googling them. Usually events that are a grade 3, 4, or 5 are considered severe and may need to be reported as serious or severe adverse events, serious adverse events. That will all come down to discussions with your principal investigator. So assessment of seriousness, so not serious. Mild results in a transient, minimal transient impairment of a body function or damage to a body structure. It does not require any intervention other than monitoring. So you can think of this as a pleural effusion, a small pleural effusion. It's noted on chest x-ray, but the docs are like, okay, it's there. We're just gonna watch it and see what happens the next day. A moderately serious results in a moderate transient impairment of a body function or transient damage. It does require some intervention to prevent permanent impairment of a body function or damage to a body structure. So now that pleural effusion has gotten bigger the next day, and they decide, you know what, let's give a dose of Lasix to see if that helps with treating that. So it's not, invasive treatment of it, but they do want to treat it. Serious results in death or can be life-threatening. So now the pleural effusion requires a chest tube. So that's an intervention, invasive intervention. It can require inpatient hospitalization or prolongation of the existing hospitalization. It results in persistent or significant disability or incapacity. It necessitates medical or surgical intervention to prevent any of the ones above, and or is considered to be a serious adverse event by the clinical investigator based upon appropriate medical judgment. So that's why it's so important that the principal investigator are involved in the adverse event screening. But serious and severe are not synonymous. A severe event may not be serious. So think of a migraine. It may be severe, but it's not necessarily life-threatening. Serious can be used to describe whether an event poses a threat to the patient's life or important bodily functions. Serious events, though, are usually severe. And then seriousness serves as the guide for defining the regulatory reporting obligations, usually for the studies. The assessment of causality, it's not related. The adverse event is definitely not related to the test article or intervention. It is clearly related to other factors such as the subject's clinical state, therapeutic interventions, or concomitant meds. Every effort should be made by the investigator to explain each adverse event and assess its relationship. Causality should be assessed using the following categories: not related, related. Sometimes the study intervention or the medication can cause more significant electrolyte abnormalities. But being sick and being in an intensive care unit can also cause some of these electrolyte abnormalities. So this is where the principal investigator will decide if it's related or not related or possibly related. Possibly related, you can have a direct cause and effect relationship between the drug and the adverse event has not been demonstrated, but there is a reasonable possibility that the event was caused by a test article. So once again, have to talk about precise because that's about the biggest thing on my mind at all times. One of our medications that we use for that, the GM-CSF, can be known to cause fevers. So the kid has had fevers, but suddenly they've gotten 2 doses of GM-CSF and now their fevers are getting up to like 38.5, 38.8, 39. They're still getting study intervention. So that could possibly be related to the fact that they're getting the medication. The event follows a compatible temporal sequence from the time of study drug administration, but it could also have been produced by other factors, such as the fact that the kid has a raging pneumonia, or they just went to surgery and they drained multiple abscesses, they have an open belly, those types of things. These could possibly be related, but in all likelihood, most of the time, it's just because the kid is critically ill and stuff, but that's where the PI has to make that determination. Probably related, there probably is a direct cause and effect relationship between the adverse event and test article or intervention, and the event follows a reasonable temporal sequence from the time of drug administration and can be reasonably explained by other factors. So big one with drug interventions, the kid has never had any of these medications, anaphylaxis, that would most likely probably be related to the administration of the drug that they got. The investigator will determine whether each AE is expected, is known to be associated with administration of the drug or the test article or the intervention, and is an expected complication of critical illness. As an example, though, you may not expect your patient to get a DVT, but a DVT is well within what can be expected to occur during the course of a critical illness on a kid who's laying in bed and not moving and has central lines and things like that. Unexpected if it is not known to occur in the setting of the subject's underlying illness and or treatment plan. With critically ill patients, I still have not been able to really come up with any examples for this. So most of the time, adverse events are noted to be expected, even death. So the actions that we take to treat the event, this pertains to any action to treat the adverse event. So either you don't treat it at all, you start a concomitant med, they might need a medical procedure like a chest tube placement or something like that, or other. Might be some dietary changes, they're having emesis or nausea or something, and we're going to change their diet, or wound care and stuff like that. You might just elevate the extremity, things like that. Those are examples of what pertains to treating the AE. The modification to the study treatment or intervention, you're either not going to modify anything, you might discontinue permanently or temporarily, you might hold the medication for that day, you might have to flip them back onto their back if the intervention is that they have to remain prone, things like that. You might decrease or increase the dose, or you might just delay giving the dose that day. You're going to delay it in the morning, and maybe in the afternoon you'll give it later that day or start it again the next morning. So those are all modifications and actions pertaining to the adverse events. And then the outcome on the daily log, this is how we track for what happened on the day from the day before. So on day 1, their fever was 38.5, and on day 2, it was up to 38.8. So we'll say that their outcome that day was that it actually worsened. On my tracking log or on your AE spreadsheet or however you're tracking for resolution of it, for what gets put into your database, you're going to want to know overall outcome. Did they return to baseline? Did they recover, but they now have a tracheostomy? Do the symptoms persist, or did they die? So the outcomes are a little different depending on what you're actually looking at for the screening. That's the end of my presentation for here. Let me just show you real quick. Please keep calm and ask questions, but there are additional events happening, how to get in touch with the PALISI coordinators, the email group that they have, and then some extra upcoming presentations for education and stuff. And they're always looking for new topics, becoming a presenter, anything like that. So please scan that QR code, and that's all I have. Does anyone have any questions? Why can't I stop sharing my screens? Ah, there's my.
Well, so far, no, all quiet on the questions front, but I just wanted to say thanks for taking the time out of your day, Lisa, to give this talk and present to everyone here. I think it was a great either refresher or learning opportunity for lots of people. And yeah, like you said, there we have some other additional training webinars upcoming that we're looking forward to. So hopefully we'll see most or all of you guys at those ones as well. And you can always reach out to the coordinator group, and we can get you in touch with Lisa or you can reach out to her directly if you have any questions or think of any that might come up.
Thanks,
All right.
CJ. All right, well, yeah, reach out. I always have my email available and stuff like that. But I hope if nothing else you learned, it's something that needs to be done, and you'll need to come up with your own processes. So thank you for asking me to present. I appreciate it. Oh, someone has a question. Oh, I see a hand, but I can't tell who it is. Go ahead and ask a question. It's a little low. You're a little quiet, but yeah, a little bit.
I had a question. Yeah, first of all, it was a great presentation. Thank you for sharing the content. I was just wondering if you would like to apply the way you outlined the adverse event tracking to our sheets, to our studies, current studies. Do you have any template you can share with us, like how to set it up for
Yeah,
students?
I have some examples of things that I'm willing to share and stuff. So yeah, just shoot me an email and I'll send you examples of my daily logs and the way I set up my AE the spreadsheet.
Perfect. Yeah, that would be great. That would be a good resource to start the process. So, thank you.
You're welcome.
All right, well, I think that was our only question. And a great call out. So thank you for that. Yeah, thanks everyone for joining, and we look forward to seeing you guys again next month. And again, thanks, Lisa, for taking the time to do this presentation for us today.
You're welcome. Everyone have a good rest of your day.
See you.
Thank you, you
Bye.
as well.
Bye-bye.